fantastic. I think the next subject we would like to briefly address, because this is a very big subject, and that is channel management. And that includes a few different things. The biggest piece of that is site of care. So the question needs to be asked, is it more appropriate to have these drugs dispensed and administered in a physician's office versus home care versus an outpatient hospital clinic or different areas? And a lot of plans have already addressed that, but there's still a long way to go. And so it really is a balance of what site is most cost effective versus what kind of support services and coordination those different sites can provide to the different stakeholders. The second piece is, of channel management, again, is medical versus pharmacy. So I think a lot of plans are looking at moving the drugs that have traditionally been under medical to pharmacy. And there are a lot of benefits to doing that, including point of service ability to know what's going on, just better access to data. But the problem with that is if one plan or two plans are doing it and their competitors aren't, they're going to look worse on paper. So they need to do a very, very good job of explaining what they are doing to people who are ultimately purchasing that insurance. And then the third thing I wanted to bring up under channel management, just kind of turn it over to you guys after this, is the role of specialty pharmacy. So a lot of, I think, plans are mandating specialty pharmacy. I am not sure that that's necessarily the way it's set up now, the right way to go. There are some misaligned incentives potentially with specialty pharmacies because obviously they're going to make their money based on refills and moving drugs. So really it is figuring out how we better use specialty pharmacy and coordinate not only on drug distribution, but of the other services that are potentially provided, like care management, and benefit determination and those kind of things.
And this is a whole new world for urology. Medical oncology has always been used to it because you all have, the medical oncologists have used many, many more oral therapeutics with the OTKIs. For the urology world, this is brand new. The concept of having these very expensive oral oncolytic therapies that go through pharmacy benefit as opposed to being billed out of our office is different. And so for the urology world, we are just now learning about this, and it's a whole educational hurdle that the urology world is having to learn. Or I think the medical oncology world has been bracing themselves and clearly presents a much bigger challenge because of the number of tumors that you guys treat that fortunately have these new oral targeted therapies.
The oral, some people call them oncolytics, but oral cancer drugs have proved to be a particular challenge because the model, if we go back a decade, was you give someone chemotherapy and you make a profit on it, and you make some money from consultation charges. Well, the oral drugs, there's no way for us to make a margin on them, and approval can take, in certain cases, 13 hours of a clinician's time, for which there's no reimbursement. If done efficiently, and it's largely set up by the pharma company or the specialty pharmacy. So we talked about whether that's got to be a model, and they actually take that burden on. And the good specialty pharmacies and good pharma companies that are looking to support this have very good patient education tools and follow-up and are relatively efficient, and will take some of that burden from the physician. Whether that's the best model overall in terms of how things are distributed. So in fact, should 20% of the cost of that drug by whatever measure come into the physician's office for us to manage and for us to do other things. Now at the moment, I don't have a choice. I have so many patients that are on oral drugs they're the new expensive drugs. I treat a reasonable amount of kidney cancer, and also the newer drugs here that my desire is to give them to a specialty pharmacy. The problem is that everything's not equal. And so my specialty pharmacy that I favour is the one that's most efficient for me and that my patients don't complain about. But there are some insurers and some pharma companies that say, we're going to do this all through X specialty pharmacy. Now, my expectation is that if the X specialty pharmacy is for, and some of them pick one pharmacy for the whole country for their drug, like physically one place, and it's all got to go there. If I don't get that from what I'm expecting from my local people who I can call up and say, hey, what's going on? This is not working for this patient. when I don't get that level of service, I don't have as much pull because I'm one of several thousand physicians, and my patient's one of several thousand. And so from that model is something that I think we really need to look at. And I've not really ever asked the payers about it, but I'd be interested in your thoughts.
Well, a lot of it is kind of the same thing. We're mandated in some cases to contract with specialty pharmacies because that's the only way we can provide drugs to our patients. So that's not ideal for us either. We would like to be able to use certain specialty pharmacies of our choosing for the same reasons you've mentioned. That we're comfortable with what services they provide, the cost is appropriate and all of those kind of things. But some of that is outside of our hands as well.
And you know, the relationships with specialty pharmacies, I mean, you go to meetings with a bunch of urologists and oncologists and everything is like urology and oncology, but that's not the world, right? Oral oncolytics represent actually a very small percent of the total basket of goods. Trend is terrible, but the total basket of goods is still a relatively small amount. And so these contracts are complicated and the relationships are complicated. We just don't have enough time to talk about this subject. We could go on for hours and hours about channel management.
Can I switch to another issue, which is administration of parenteral drugs? So I mean, non-oral. And we've seen a pattern in California where, and it hasn't been necessarily the biggest insurers, but some medical groups now have their own injection area, injection rooms, and not just for cancer drugs. And this usually is fine if we can connect, and I can't tell you that I can give a better Zometa infusion at USC Norris than at an infusion centre in Pasadena, which is 6 miles away and closer to the patient's home. But there is a huge educational gulf in the people that work at these centres. They may be able to get an IV in, but they don't know about the drugs. They are not physician supervised by and large. And we have issues with, so denosumab's been released. Well, trying to switch my patient in one of those centres from Zometa because he's getting progressive renal impairment to denosumab, it was fraught with difficulty. They couldn't get the dose right, they'd never heard of the drug. He showed up and they didn't have the drug. He showed up and they tried to give him a subcutaneous injection of Zometa, which is interesting but not ever been validated. So, you know, we're having some issues with those centres, and I don't mind them, the cost differential being reduced because it's done that way, because, you know, we are expensive. And I don't think in terms of healthcare economics we can justify being more expensive, but I have a tremendous amount of expertise on site, and we have our issues, we deal with them, but we know what we're doing related to cancer drugs. So I don't know if there's a comment on that.
Yeah, well, in our defense, when we talk about site and where we would like these drugs dispensed, we can look no further than MS and RA as a reason for why we are not, generally speaking, big fans of this, because there are definitely shifts in certain providers to drugs that are infused versus self-administered or oral, because they have infusion suites. And when you ask them why they're using certain drugs, it's because they make money doing that. So again, it's misaligned incentives, and if we can kind of address that and maybe equalize the payments that we're paying you versus an infusion center versus home care, then we don't care about it.
It gets back to the issue of me as the medical director, knowing that you're telling me that I'm more expensive to give this than the infusion center in Pasadena, and me going back to my people and saying, hey, you know, let's get real here. We're not going to be able to charge more for the administration of this subcutaneous injection than the people there. And if we want to maintain our care model and keep the information nice and have me oversee it, because I'm physically there or someone covering me, we're going to have to align our costs to be at least equivalent to these other people.
So there are at least 3 published reports now on the differential of site of service. They all show that hospital outpatient departments are between 40 and 200% more expensive than community-based offices. And as you said, denosumab subcutaneous is the same in both sites of service. And you better talk to your hospital administrator before you start thinking about whether or not you want to negotiate that site, because actually these are complicated contracts, right? And they're even more complicated with academic medical centers.
But that's true even for a surgery center. You know, I mean, to do the same procedure at a hospital-based surgery center is much, much higher than the same procedure at a freestanding ambulatory surgery center.
So that's why, as academic centres, we're building different models to give that care. So we now have an infusion centre in Pasadena, but it happens to be a 1206D clinic. And we've had these discussions, and we have a discussion at our centre about things that are going to change, it's like what you guys do. Looking ahead, we say, you know, we're not going to be able to give this subcutaneous injection here. We need to not be addicted to the margin benefit over time. We need to predict that that's actually going to fall. And then there'll be other things where there is a margin for a variety of reasons that'll keep things going. What we're actually more interested in is maintaining quality of care. And if it's better for the patient to get that subcutaneous injection, in quotes, with us, so it's in our EMR, then I'm fine with it. What I expect of it being given outside is that it be given right, in quotes, and that we actually be informed that it's given, so we know what therapy the patient's had and we can track it.